can I remove this thing?
Second.
So now you all would appreciate that an MBBS graduate, when he goes, when he passes out, he goes to the field to work. So he is basically not that confident as you could say, for example, a physiotherapist. A physiotherapist, when he goes to the field, he can straight away start his practice, and same is true for the dental people also. BDS वाले जो लोग हैं वो they उनका practical aspect जो है teaching में इतना ज़्यादा होता है that when they pass out, they straight away start their practice and they are quite confident enough. The same cannot be said of a MBBS graduate. So the thing behind this making them a part of the healthcare team is that a MBBS graduate, when he passes out, he should be able to do the things independently. He should be able to provide good medical care to the society. Basically, he should be able to do what is expected of him as a healthcare graduate. So this is the rationale behind making him a part of the clinical care during his stint in the hospital setting. So the goals are basically these, that he's involved in the longitudinal patient care. That means he's a part of the department. He observes the patient from the admission to the discharge. He becomes a part of the healthcare team and is expected to do things in a supervised setting. He's given hands-on care of the patient in the inpatient and in the outpatient setting. But the word supervised is very important. The faculty members are there to supervise him. All these things are done under a supervised setting. So the journey starts from here. He is assigned to a medical unit or a surgical, pediatric, obs, gynae, or an ortho unit during his clinical rotation. So as his duty may be, as his posting may be. And he functions as a supervised member of the team. He would participate in pre-specified team activities, which would involve the patient care as well as learning. And all these things are documented. Whatever he does is documented, his progress is documented, and later on, an assessment of his learning is also done, and this is documented in his logbook. So when he's assigned to a medical unit or a surgical unit, this involves he's provided orientation towards the patient, towards his role as part of the healthcare team, and towards his role in the society. So this is done in the first clinical posting of the second professional year. So the second professional year, in each of the professional years, his roles are basically well defined. When a student of second professional year would come to you, so you would give him tasks which are basically to orient him to his to the patients in the wards, to orient him to his role when he's a part of the healthcare team. So this would be what is expected from him in the second professional. A designated faculty member would coordinate and facilitate the activity of the student. And this faculty member should ideally be also responsible for the care of and the decision for the patient. So whoever faculty member, whoever consultant is in charge of the patients, so he will coordinate and facilitate the activity of those students who are under him as part of his team. Then he functions as a supervised member of the healthcare team. He will be a part of the admission team on the admission day. For example, there are 6 surgery units, each has his admission day. The students, the batch of the students is divided into all these 6 units. So the student who is part of the admission unit on the day of admissions will be part of the admission team. He will observe how the patient is worked up in the outpatient, how the patient is admitted, he is sent to the ward. And he will be assigned patients in the outpatient also to interview, to examine, and to do the workup. He will be assigned one of the admitted patient also to be interviewed, to be physically examined for his workup and for the follow-up. So this he will not miss his classes. This he will be doing only in the time period which is the time allotted for the clinical class, for the clinics. That means around 3 hours. And during designated theory class hours, he will be leaving the team. He will attend his theory classes. He will again come back to his unit after his theory classes are over, and he will remain with the admission unit until 6 p.m. So that essentially means that, for example, if the hospital class is from 10 to 1, so he will be leaving at 1 for his theory class. He will go and attend his theory classes. Maybe at 2 o'clock, when he finishes his theory class, he'll go for a lunch. He will again join the unit at 3 p.m. and he will remain until 6 p.m. with the unit. He will also participate in the unit rounds on the admission day. So all those students who are posted with you, they will participate in your rounds. They will participate in the unit rounds at least on one other day also other than the admission day. So they will follow and document the progress of the assigned patients during the course of hospitalization. Each student will be assigned a patient for whom he will do the follow-up. He will observe how he is worked up, how he is managed, how he progresses, what is the course of action during management, and up till the discharge of the patient. So that one patient will be allotted to the student who he will be regularly following up till the discharge of the patient. So during this interaction with the patient, during his assignment with the patient, he would be assigned tasks, which some of them he can do by himself. Some of them would be just observations. Some of them would be done under a supervised setting. So this is basically essentially the decision of the faculty to decide whatever things he can do, whether by himself or whether under supervision. And as part of this, he can participate in the procedures, surgeries, and deliveries. Participation again means, I think, on the part of the MBBS student, it would involve just observation of the procedures and surgeries and delivery. So based on the responsibility which he is given as part of the team. So these participation in the pre-specified team activities of the patient care and learning as part of this, for example, these activities are pre-specified for each professional year. For example, a first year professional would just be introduced to the hospital environment as part of his early clinical exposure, just to understand the perspective of illness. As part of this, maybe the first prof departments would be taking him on hospital rounds, just to show him the processes, how the admission is done, where are the admission counters, how the admission is done, how the patient is then shifted to the ward, understanding the type of patients that you usually get in a hospital. So general introduction to the hospital environment. So that is a part of the first professional. So as part of the second professional, when students of second professional are coming to you in the clinics, he would be expected to take histories, do a physical examination, maybe under your supervision or maybe under your teaching, assessment of change in the clinical status. Now, mind you, the student is allotted a patient for longitudinal care as long as the patient is there on that bed. So he will be daily assessing the change of that patient in his clinical status, what all treatment is being given, and he would also be communicating with the patient, maybe if you allow him with the attendants also, again as part of his teaching in a supervised manner. And basically you could give him some activities related to patient education also, that he could talk to the patient regarding his disease. He could give some general tips on education. So a second year professional would be expected to do all these things. As part of the third professional, when a student of third professional part 1 is coming to you, he would also be over and above the things he does as a second prof student. So over and above, he would also be expected to participate in the basically deciding the choice of investigations, basically some knowledge about the basic procedures, and of course the continuity of care. Continuity of care as part of, again, the patient who is allotted to him. He is regularly observing that patient every day. He's observing his progress. He's observing his course of clinical care. So he is also a part of the continuity of care of the patient. Now, as the student grows in stature from part 1 to part 2, he would be a part of the decision making. He's expected to be part of the decision making also. He's expected again to be part of the management and the final outcome of the patient. So what I mean to say is that although a second year professional is also longitudinally observing the patient, a third year professional part 1 is also longitudinally observing the patient. A third professional part 2 student is also longitudinally observing the patient, but the expectations from the student are different in each of the professionals. So as given here. What is the significance of this? The significance of this is that we have also to document his achievements, that he has achieved what is expected of him. He knows how to take a history. He knows how to physically examine. A third professional, he knows how to make a choice of investigations. A third professional part 2 student knows how to make decisions about management. And these are to be documented in his logbook. And also a formative assessment has to be done regarding what is expected of him. So as part of his team activities, he also has to present the assigned patient to the supervising physician on the admission day. So if he has taken the history, he has done a physical examination, he would be presenting his work to the supervising physician on the admission day or during unit rounds. So he is, of course, participating in the team activities, including in the rounds, and he is fulfilling his learning responsibilities, which are assigned to him. Now, all these things are to be documented, as I already said. Whatever he's doing, he has to document his patient encounters as well as his learnings in a logbook. And this logbook is to be assessed and signed by the supervising physician. Obtaining feedback from the supervising physician, and not just the physician, other members of the healthcare team. Other members of the healthcare team could be the residents, the other faculty members, the nursing staff. Feedback could also be from the patient, which is assigned to him. Feedback could also be from the relatives of the patient, which has been assigned. So an overall feedback, a multi-source feedback from all these entities would be required for him. And this feedback would also be documented in his logbook. And all these logbook entries and the supporting case records are a part of the document which he is to submit as prerequisite for appearing in the examination. So this whole process, this process of learning, being a part of the healthcare team, has not only been formalized, it has also been made a prerequisite for appearing in the examination of the concerned subject. So what all do we want to achieve by this activity? So the learning plan here is like data gathering and arranging it in a meaningful fashion, which the student is doing by obtaining a detailed history and physical examination, and arranging this data here is the history, the physical examination findings, arranging it in the case sheet or a shadow case sheet. Of course, the student will not be given the original case sheet of the patient. He will be given a similar case sheet, shadow case sheet we call it, in which he will be documenting his findings. As part of making him critically think and analyze, so he, after obtaining history, after obtaining the physical examination findings, documenting it, He's also analyzing the patient's problem. What is the differential? What can be the differential diagnosis? Maybe under your supervision, under the supervision of the supervising faculty member. He's coming over to decision making by developing a management plan. He is also expected to choose, order, and interpret appropriate tests, again in his shadow case sheet, based upon the clinical condition of the patient, maybe based upon the economic condition of the patient, also based upon the cost effectiveness. So he is ordering the appropriate lab and imaging tests. Of course, this is also according to which prof the student is in. For example, this thing would be done by a third prof 1 patient. So a third prof 1 student. And then finally, decision making, choosing the appropriate management therapy, writing a prescription, and even use of electronic medical records if we are doing it in the hospital. So this would be expected from the third prof 2 student. So basically what we mean to say is that all these activities are meant to achieve all these learnings. So this is the rationale behind all these activities which the student is supposed to be a part of. Now, again, discussing the diagnosis and treatment plan with the patient. This is a part of his learning, his communication skills, becoming a participant in the patient rounds and the team activities, make him exposed to how a team works, what are the dynamics of working in a team. Again, participating in rounds, participating in ward-based procedures makes him exposed to the clinical skills, and of course working in a team. And chart review and participation in quality initiatives in the patient care. So basically viewing the patient progress charts, participation in other quality initiatives. So this makes him exposed to what are the coordinates of system-based practice. Self-directed learning, skills for lifelong learning. Now you all know that when a patient is examined, when he's a differential diagnosis is made, a treatment plan is made, frequently you also have to refer to the literature, refer to the books, refer to the internet, refer to the recent basically the recent advances in that. So maybe you have to review the literature based upon the patient's problem, and you have to make decisions based on that. So these all are part of the self-directed learning, skills for lifelong learning, which we people are doing even up till now. So he's also exposed to this thing that no, it's not just that you finish your MBBS and the books are closed here. So this is a part of the lifelong process of learning. You are expected to be searching for new things, searching for knowledge, searching for literature throughout your life. So he's also expected to write reflections on his patient encounters in a clinical and psychosocial context. So in your basic course, all of us must have, I think you must have been introduced to what is a reflection, how is reflection written. And so we also expect the student to write reflections on his patient encounters, both in a clinical setting as well as in a psychosocial setting, psychosocial context. So now, just a minute. How do we remove all these things here? Okay. So now, as part of this learner doctor program, some tips for the faculty basically. So you have to choose competencies that can be acquired by the student in each rotation and in each subject. This is
Somebody is writing. Dr. Kumawat sir is writing.
Kumawat sir, I think yes, Your
Annotation is on.
annotation is on.
Mouse.
So when these students, they are coming to us in the clinics, and we implement this whole learner doctor program. So basically, there are some things which we need to keep in mind. So we need to choose the competencies. Competencies are in fact already given in the NMC document, all those competencies for each clinical program which the student is to acquire. So we need to choose the competencies that can be acquired by the student during his clinical rotation. And from those competencies, we need to determine the activities that he should be learning, he should be assessing and recording. And the faculties will need to be trained for this need assessment for work-based teaching. And this is in fact a part of the faculty training program only. And the supervising physicians and the team members, they are to be oriented on their roles and expectations. And a whole process of feedback from multiple sources has to be created for improvement of this program at our level and at the system level. So now an example of all these things, what competencies can be chosen, what activities from those competencies can be chosen, I'll be showing you in the later slides. So for example, in orthopedics, there is a competency: elicit an appropriate history from a patient or a relative presenting after an accident. So this can be given to a student as part of his clinical posting. This is a very well a clinical competency which addresses the psychomotor skills, and so this can be given in a clinical setting. Similarly, in pediatrics, assessment of a child with obesity with regards to eliciting history, including physical activity charting and dietary recall. So history taking and basically this is a part of history taking only, which can be given to a student during his clinical posting. Examination, including calculation of BMI, measurement of waist hip ratio, etc., etc. So this is a part of the physical examination skill. So basically, you have to see that basically the cognition part, that is addressed during the theory classes, and during the clinical skill class or during the clinical skills posting, during his clinical posting, he is given activities which cater basically to the what we say the psychomotor skills, the affective domain, the psychomotor domain. Similarly, in surgery, communication and counseling the patients and families with burns on the outcome, and rehabilitation, demonstrating empathy and care. So again, this could be given while during his clinical posting. Observe common surgical procedures. And so mind you, all these are competencies which are already given in the NMC document, which the students have to acquire. So observe and assist blood transfusion, assist in close reduction of shoulder dislocation, hip dislocation, knee dislocation, or assist in MTP in the first trimester. Educate mothers on antenatal breast care and prepare mothers for lactation. So all these activities can be assigned to the students during their clinical classes. So from these competencies, you can determine the activities based on patient availability, based upon the illness which is prevalent at that time of posting, and whatever can be done in a busy environment, because all the clinicians would be busy, and whatever can be best done in such an environment. So those activities you can always give to the student. Ensure a mix of activities that provide for application of knowledge, for the application of knowledge. So the key word here is application of knowledge, not just knowledge, application of knowledge for improving his skills for development of reasoning, teamwork, communication, ethics, and use a framework that will allow the documentation of such activities. So all these activities are meant to be documented also, and so such activities which you can conveniently document in a logbook, which can later on also be assessed. So such type of activities should be chosen. So, for example, again, this is an example that the competencies elicit, document, and present a medical history that will differentiate the etiologies of diabetes, including risk factors, the precipitating factors, lifestyle, etc., etc., etc. Now, this activity is meant for the year 2, and to acquire this competency, what activity the learner can do, he can elicit the history, he can document that history in his portfolio and logbooks. He can present that history during the unit rounds, and later on, for formatively assessing this activity, you can observe his presentation, the presentation of history during the round. You can assess his case record in the portfolio, whatever he has written, the history, whatever he has written in his portfolio. You can validate his logbook entries for the same, and then you can provide a feedback. So similarly, there's another example which can be done by the year 3rd students. Perform and interpret a urinary ketone estimation with a dipstick. I don't know whether such kind of procedures we are doing here, because we do not have site labs. But maybe this is also part of the NMC document. Maybe medical colleges which have a site lab, there the students are doing this, or maybe they are expected to do this. So in year 3rd, part 1, this could be the competency from which this activity has been extracted. That means explaining the procedure to the patient. He should be performing the procedure as specified. He should be interpreting the results, and he should be documenting this in the logbook also. So how to assess this? The procedure can be observed. His logbook entries can be checked, and he can be provided the necessary feedback on this. Again, an example of a student of 3rd Prof 2. So he could, the competency here expected is outlining a therapeutic approach to a therapy of type 2 diabetes based on presentation severity and complications in a cost-effective manner. So the activity which can be given to achieve this competency can be reviewing a patient. Reviewing a patient means his history, his physical examination, which is already taken, that has to be reviewed, and based upon that, a therapeutic plan is to be proposed. This proposal is to be documented in his portfolio or logbook. This is to be presented to the supervisor. And to assess the student, you could assess his presentation, you could assess his therapeutic plan, you could review his portfolio, you could check his logbook entries, you could provide a feedback. Something similar here, competency, recognize the importance of patient preference while selecting therapy for diabetes. Again, activity proposed is to discuss the therapeutic options with the patient, to elicit and analyze the factors which determine patient preference, and writing a reflection in the portfolio. So now you see here that here the competency was recognizing the importance of patient preference. So now this is a sort of a basically a not just a clinical entity, but a psychosocial context. So reflection here, writing a reflection in the portfolio would be important here, because this is something about patient preferences. So he has an encounter with the patient, he discusses the therapeutic option available with the patient, he analyzes the factors which determine the patient preference, and then he writes a reflection in his portfolio about what made the patient choose such and such option. So assessment of this can again be done by reviewing his reflection, what he has written in his portfolio, and by checking for his logbook entries. So this is an example of the logbook entry. So logbook entry is done something like this. You write down the number of the competencies which is given as you all know in the NMC document, that each competency is given a number. So you write down the number of the competency, you write down the name of the activity which the student did to achieve that competency, date on which this activity was done, attempt at activity, was it a first attempt or was he making a repeat attempt or a remedial attempt. So first attempt is of course when he does it for the first time. A repeat attempt, if he has already done such activity before, he is doing it second or the third time. Remedial is when during his previous attempt, you have marked him as unsatisfactory. He doesn't meet expectations. So you have asked him to repeat the activity. So remedial is that when he is doing it as part of the assessment which you have done and you have asked him to repeat the activity. So a rating can be given for his activity. It can be if he exceeds the expectations, it can be E. If he meets the expectations, M. If he is below expectation, B. So decision of the preceptor. Preceptor is the supervising physician. So if he meets the expectations, okay, that means his activity is completed. If he is below expectation, then here it is, you have asked him to repeat it. And again, if he meets the expectation, the activity is marked as completed. And here your comments, deficiencies which are identified and corrective activity, he has to repeat it again. So you can again assign him a date, a time to repeat that activity. So something for the supervising physician, some do's and don'ts, that the students should be briefed clearly about their expectations, about their expectations as well as about your expectations from the student, that what he is expected to do, what he is expected to achieve as part of being a member of the healthcare team, what would be his role and what would be his limits of autonomy in patient contact. Of course, a student would most of the things he would be doing supervised. He would not be given independent chance. He would not be given he can take history, he can perhaps do a physical examination also, but other things I think he would be expected to do in a supervised manner. So follow institutional policy with regards to access and documentation in patient reports. We must ensure that the institutional policy here is followed. If the student is not authorized to access certain reports, he shouldn't be allowed to. That is basically the policy of the unit or the department or the institution. So the student is to be introduced to the patient whose charge he is being given. Permission from the patient is also to be taken for the patient, for the student to examine him and be involved in his care. And in case the patient does not wish that a student should be a part of his care, then I think that wish should also be respected and arrangement made accordingly. We must not forget that students are there to provide, they are basically to learn and to learn as they work. And they should not be overburdened. I think their limits should be understood. A maximum of, say, I think of one patient is usually sufficient to be given to them as part of their learning for longitudinal assessment. So at a time, a student should be having only one patient preferably. So learning in this program is on the job. Other methods of work-based learning and assessment can also be used. And care should be taken about addressing the concerns of ethics, empathy, communication. So we must ensure that students perform activities on patients which they are certified to perform independently, and the rest of the activities should be under supervision. So, this security of the students is one of our priorities. And time allotted should also be respected. It's not like that they should be made to sit in the ward from the morning to evening, and it should be, we should properly understand that how much time is enough for them. So it is, these whole documents, this whole guidelines are basically to be taken as guidelines only. These are to be fine-tuned according to our own assessment, our own experience. And students should not be asked to miss their pre-scheduled classes. They are expected to attend to their theory classes, even when they are as part of clinical team also. They have to go to attend to their classes. And if there is any doubt, you should also always refer to your hospital administrators, to the hospital rules and regulations. So feedback from all stakeholders should be used to implement this program at the institution level, and faculty will be provided actually with a copy of the feedback from students to help improve their performance. And feedback may also be requested by the NMC as part of this program through their nodal centers, which is meant for program improvement and course corrections as required. As you all know, the curriculum committee is headed by the principal or the dean, who is overall responsible for this program. So departmental heads, unit heads, and the supervising physicians, they are accountable to the curriculum committee for the implementation of this program. And the MAU is going to provide the faculty development programs based upon the need, as we are doing it. This introductory program is a part of the MAU program for faculty development regarding this new initiative. This is an extract from the Gazette where this program has been defined. So the goals, as they have defined in the Gazette, we have already discussed that the student is expected to be involved in the longitudinal patient care as part of the healthcare team, and he's expected to have a glimpse of the hands-on care of the patient in the outpatient and inpatient settings. So basically, it means that the student is to be involved in the working of the healthcare team, so that he is well versed how a healthcare team in a hospital setting works, how it takes care of the patient, how the patient is managed, how the patient is followed for his progress right from his admission to the discharge. And the structure of this program, the first clinical posting and second professional, it orients the learner to the patient, and the specialty, the learner doctor program progresses as is outlined below. The student is expected to be part of the unit's outpatient services on admission day. He remains with the admission unit until 6 p.m. except during designated class hours. He is assigned patients admitted during each admission day, for which he will undertake the responsibility under the supervision of a senior resident or a faculty member. He participates in the unit round on the admission day. He also presents the assigned patient to the supervising physician on the rounds. He follows the patient's progress throughout the hospital stay until discharge. He participates under supervision in the procedures. He participates in unit rounds on at least one other day of the week. He discusses the ethical and other humanitarian issues during the rounds. Despite being a part of the team, he attends all his scheduled classes, all his other scheduled classes and educational activities. And this thing is formalized by documenting all these things in a prescribed logbook, which is to be assessed and given a satisfactory rating before he's cleared for his examinations in that particular subject. No learner is to be given independent charge of the patient. As a student, he cannot be expected to have an independent charge of the patient. He's to be supervised. The supervising physician will be responsible for all the patient care decisions. For assessment, they have given in the Gazette that a designated faculty member in each unit will coordinate and facilitate the activities and monitor the progress, provide the feedback, review the logbook. The logbook must include the written case prepared, the relevant investigations, the treatment, the hospital course of the patient, the family and patient interactions, discharge summary, etc. And the logbook should also include the records of the outpatients. Even in the outpatients, the patients are being assigned, so those are also to be entered in the logbook. And submission of the logbook is a eligibility criteria to appear for the final examination of the subject. So focus, again, as we already discussed in the year one, it would be basically a general introduction to the hospital environment, early clinical exposure. In year two, it would be history taking and physical examination, or the assessment of change in clinical status. Basically, this is observation of the patient, communicating with him, educating him. In year three, in addition to all these things, investigations, basic procedures, and being involved in the continuity of care. And in the final year, all of the above, and also participation in decision making and management and final outcome of the patient. So with this, I thank you all for being a part of this program. We are open to questions. For questions, there are two polls which I would want you to answer. I should launch it.
Yes.
Okay. Mhm.
Quickly submit the poll so that we can let you know.
There are few participants remaining to submit the poll. Please submit it so that we can move ahead. Okay, so another poll. Yeah, so 28 people answered this poll, and all of them they marked the correct option, observing the process of patient care. So as we all learned in this, performing minor procedures on the patients independently is not part of what is expected from these students. And so they are also expected to attend the theory class during their period of clinical posting also. Of course, you don't want them to do menial errands like taking the referral registers to the departments. Maybe they can be a part of the, if they want to be a part of, they can accompany the resident or something if they want to discuss with the other consultant regarding something about the management of the patient. So then they can be a part of the referral team going to make a referral to other department. So the next poll is this. Please answer it as quickly as possible.
part 1, part 2.
So most of you have answered it correctly. It's part of the part 1. It can also be a part of the part 2, but yes, a part 1 student would also be uh, expected to order the investigations, to know the rationale of the investigations which are being ordered. So around 95%, 92% of the attendees have marked it correctly. I take it as a pat on my back.
Stop sharing the screen.
Okay, stop sharing. Stop sharing.
Okay. Put it on the board view so that we can see the others can also turn on their cameras so we can discuss, take up your doubts. You can unmute yourself and we can discuss. Good afternoon, everyone. I hope we have discussed and touched upon the topic regarding the learner-doctor method of clinical training. This is something which is going to happen. The clinical postings will be now conducted in this format only. This is as prescribed by the National Medical Commission in the new CBME-based curriculum. Initially, what used to happen was the students who used to come to the OPD, we will allot them a case, they will discuss the case, one person will present history and they will go back to their classes. But now in this pattern, we have to allot cases to the students and they will be responsible for the longitudinal care, I mean, observing the longitudinal care of the patient. So we are open to the questions now. If anybody has any question, they can raise the hand. We've given you the controls to unmute yourself.
Ma'am, there is a question from Dr. Nitin sir
Yes.
and Dr. Sushma ma'am.
Yes.
They are asking one patient can be allotted to how many students at one time?
So ideally, you know, the ideal case scenario is that you are allotting one patient per student. But depending on the feasibility, you can even club the students for a case. Like you can allot it to 4 to 5 students. You have to work on the feasibility at your ward level and your OPD level.
ये क्या हुआ भाई मेरा नाम क्या होगी
Any other question? Any other questions you have? We can take up the questions. Yes, Dr. Nutan, you have a question?
What I want to ask you, somewhere two instruments are working in the same room. That is why so much static noise is there. somebody is having two instruments at one place, please switch off one instrument.
Yes, Dr. Nutan, please, you can ask your question.
What I wanted to ask was that isn't it asking for too much when a first MBBS student comes to the first MBBS to put too much in his brain when he's not well versed with even the basics, I mean, this is my query.
Dr. Nutan, first of all, this is not for the first MBBS students. The students will be posted to you in second professional, and in first MBBS, they are already exposed through the early clinical exposure. There is a slight change. You must have observed with the students from 2019 onwards that they are sensitized for the application-based knowledge. Even their question papers, they have turned to CBME-based question papers. They are more clinically oriented. The clinical case-based scenarios are given in all the subjects of first MBBS, second MBBS. So that is there. The question papers, the theory question papers also have the case-based scenarios under the name of early clinical exposure. And second MBBS, when they will come to the hospital, so they are supposed to do the physical examination and history taking. Rest they will, this is what is expected out of a second professional student. And they're already doing it. You know, his clinical examination and history taking is something which a second prof student should know. Right now, what is happening, the second professional student is just sitting in the canteen and not visiting the hospital. So we have to bring them back to the hospital.
And mainly the thing is that the interaction at present is just an episodic one. He takes the history that are, he goes back. Not a what happens to the patient after that, or what does it mean to care for a patient in a hospital? What is the longitudinal care? What is the how a patient is assessed? How is he is followed up? What are the outcomes? So he's basically not immersed into all these things. Maybe he is expected only to take history and physical examination. Rest of the things he just needs to observe as a part of the healthcare team. He's not expected to do anything more than that, but he's just expected to be present over there. He's just expected to be well versed with all these things which are involved in the longitudinal care of the patient. So as he progresses, as he goes to his third prof 1, as he goes to his third prof 2, maybe the expectations also increase.
Dr. Ravi had raised his hand. Dr. Ravi had raised his hand. You can unmute yourself and ask your query.
How to assess the patient, the students, ma'am? Can you please elaborate?
Okay, so now the logbook has been introduced even for the phase 1 students, phase 2 students, third part 1 and third part 2. So in second professional onwards, Dr. Ravi, you are from medicine department, I assume?
Yes, ma'am, I am from medicine department.
So now the second professional MBBS logbook will also have the component for all the clinical postings in which the student is going to. So similarly in phase 3 part 1, that is the pre-final and in final year also. So all the competencies which are given in your competency document, you have to break them up, that what to teach in second prof, what to teach in third part 1, what to teach in third part 2. So those competencies have to be aligned with the theory and the clinical posting, so that if a student comes to you in January, a batch comes to you in medicine in January, and the other batch comes to you in June. So your basic teaching pattern is same across all the batches. So you have to decide what competencies you are going to teach in second prof, what competencies you are going to teach in third part 1, what competencies you are going to teach in third part 2. And how you are going to build up on that, build up on those competencies. For example, there is a patient of diabetes mellitus. So his history taking, you will be focusing in year 2. His investigations you will be focusing in third part 1, and his treatment plan and counseling part you will be focusing in third part 2, right?
Yes,
And
but
it has to be documented in the logbooks, and you will be assessing the logbooks and their reflection. That is why the supervising physician is actually acting as a mentor.
But the investigation part, the management part,
It
that
has
is
to
being
be-
observed by the students even of the second year also. Though they are not expected to be knowing all those things, they are not to be assessed on all those things. But as part of the team, they are actually observing even what is being done by the third year students, part 1 students, what is being done by the third year part 2 students. So.
Dr. Gaurav, you have a question? He's on phone, it seems. Yeah. Anybody else with a question?
Just one query.
Yes, yes.
Yes, madam. One query.
Yes, Sareen, sir, you're audible.
When in the first professional, after first professional, our student he has learned about history, then second professional about the physical examination, then the investigation, and in the last, in the part 2, they are coming for the management and everything. We'll have to refresh that also, not in this the history and physical examination. Otherwise, it is about 3 years.
It was written, no, all the above things and one step ahead.
So some part of that, and then in details about it.
The next, any other queries we can take up?
Hello.
Kumawat sir, yes, please.
My question is, the student will maintain the log book and history sheet also, or log will contain the history sheet?
Sir, the shadow case sheets हैं, that now we will include it in the logbook itself for each department. We may have like, अगर आपके पास medicine में unit 1 का admission day हफ्ते में एक दिन आता है, for example, so हम उसको ज़्यादा से ज़्यादा 6 केस दे देंगे 6 हफ्ते की पोस्टिंग में. So उसकी logbook में हम 6 shadow case sheets या at most 7 shadow case sheets already उसकी logbook में हम डाल के रखेंगे. Now this shadow case sheet will be a replica of your clinical case file.
Yeah, thank you.
Any other questions we can take up?
Ma'am, here I think we can mention one thing,
Yes.
that this student doctor learner method में जो जिस case को follow कर रहे हैं, that will also be mentioned in the logbook
Of course.
under the heading.
So that necessitates के जो HODs and they should assign one nodal officer जो कि coordinate करे with the curriculum committee to finalize their logbooks as soon as possible, especially for third part 1. The coordinator for making up the logbooks on the clinical aspects is Dr. Manu Sharma, Dr. Nalini, and Dr. Suman Parihar. So they'll be taking, and we really want a volunteer from pediatrics department to coordinate, because these are the 4 major departments which should come together and formulate the logbook sitting together, and they have to incorporate their sections into second professional, third part 1 and third part 2 also. So first of all, I think the curriculum committee has already called up the meeting for finalizing the timetables, as the third part 1 is scheduled to start from 31st January of this month or probably 1st of February. So third part 1 is beginning by the end of this month. Second prof might begin from the first week of February, and we have to do all these logbooks and the timetables before we get the students. So this is of prime importance right now. And the next meeting, which we will be conducting from the medical education unit, will be on integration and alignment according to the new curriculum. So if you have further more questions, we can take up the questions. Bhaumik sir, you have a question? Another thing which you must have noticed that Dr. Harpreet was time and again telling that the student has to participate in the rounds, the clinical rounds. And our clinical postings, they begin from 10 to 1. And by that time, I assume all of you are done with your rounds. So how do you propose to incorporate the students in the rounds? I am inviting the suggestions on this, that how do you, as the senior faculty members, we have all the senior faculty members here. Kumawat sir, how do you propose that we can incorporate the students in the clinical rounds? Because our timings are from 10 to 1 for clinical posting, but our rounds happen before 10.
In fact, usually from 9 to 10 is the ICU rounds are there, then the ward rounds, they are after 10 o'clock, usually it is after 10 o'clock. So
On admission day, probably that would be your OPD also. You would like to go to the OPD by 10 for most of the departments.
at the time of the ward round, we can involve them in the ward round. Otherwise, some days in the morning in the ICU, and then of course in the OPD after the rounds.
There is one submission here because when we were talking to the nodal center about it, they said you can change the clinical timings from 9 to 12 instead of 10 to 1. So that the students, they are part of the rounds. So they can have their theory classes from 8 to 9 and then clinical posting from 9 to 12. And then again, the classes thereafter for 2 hours.
Okay, yes.
So this we will finalize only after the college council meeting because it is going to be a major change. I cannot say anything on this platform regarding that.
So also we can ask him also. Then I think.
Any other questions which we can discuss? Any other? So before we conclude the meeting. I think most of the problems they are sorted, and so this is what lies ahead of us when we are going to go in for the clinical rotation from this year for second professional and third part 1. So we are going to implement the same thing even for the third part 2 students, because this is not a bad thing to do and might as well absorb all the students in the same clinical pattern of teaching. So,
Excuse me, ma'am.
if we have any problem, we can still meet again for a troubleshoot. Yes, Nalini?
Ma'am, for the sake of the participants, am I audible?
Yes, you are.
Ma'am, I just wanted to ask that do we have to give it in writing anywhere to the college committee when a particular department is going to hold the student doctor learner method in their postings?
Now there is a confusion. Whenever is your admission day of your unit, this is the method. You are going to allot the patient on that particular day. The patient will be followed up till his discharge. He may be discharged the next day. He may be discharged till the next admission day. He will not be allotted a next patient till that patient is discharged. Very clear.
So the question is, ma'am, that does the department require to submit it somewhere in written?
Yes, Dr. Lalli. We have already asked last year from all the clinical departments, and all the clinical department already submitted the routine of their every week for 1 month or 15 days clinical posting, how they are going to basically take Monday, Tuesday, Wednesday, like that. I think so most of the HODs are well aware about that. They have already sent this detail to Dean Office. Am I right, Dr. Majinda ma'am?
Yes, we'll need to get the document, similar document, part 1 also.
Yeah.
Boss, my question was about designating one single day. We are talking about unit wise for the student doctor learner method only.
Basically, this
My
student
question was specifically for student doctor learner method. Does that need to be documented somewhere?
this student doctor learner method is not in isolation. What we are already doing in that format, this student learner doctor is to be included. So this is not something which, in fact, we are doing in isolation to other things. Those things which we were doing before are to be done. Arvind talked about those things which are to be taught to the students during the course of their clinical setting. So those things are basically mainly outpatient procedures or mainly indoor procedures which were just say for an hour or two, they were episodic. So along with those procedures which we will be doing anyways, we are also to be giving him a patient which he will be following up for longitudinal care. So this is the only change here. Rest all the things which we were doing before, we are going to continue.
Routine OPD teaching plus one patient.
Yeah.
Will continue.
So the previous things plus one patient to follow. This is the only crux of all this.
Thank you, sir. Thank you, sir.
So we end the meeting. And the next meeting, we will share the schedule. It will be on integration and alignment as per the new curriculum. Thank you, everyone. Thank you, Dr. Harpreet. Thank you, team Medical Education Unit, and thank all the faculties and the participants for being such a good audience and participating in the discussions. Thank you so much.
Thank you.
Thank you, ma'am.
Thank you.